Hello and welcome to Grand Rounds for the Minnesota's Regional Spinal Cord Injury Model Systems, or MinSCIMS as we call it for short. I want to thank everybody for joining us today. MinSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, NIDLR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please. MinSCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide. Our community collaborators include the Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, the United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehabilitation, and post-acute services. My name is Dr. Kimberly Mondin, and I will be the moderator of today's session. I'm an assistant professor in the Department of Rehab Med at the University of Minnesota Medical School and co-project director of the MinSCIMS with Dr. Leslie Morse. Next slide. A few housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MinSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the chat and Q&A functions. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly. We would also like to thank Dan at the University of Minnesota for all of the work behind the scenes to make these webinars possible. Next slide. The title of today's presentation is Individualized Pressure Injury Prevention, Harnessing the Power of Pressure Map Data Across Multiple Contexts. The speakers for today are Drs. Tamara Vos-Draper, Christine Olney, and Missy Morrow. Tamara Vos-Draper is an occupational therapist and assistant professor in the occupational therapy program in the College of Pharmacy and core faculty in the Rehabilitation Science graduate program in the medical school at the University of Minnesota. She received a Bachelor of Arts degree in occupational therapy at St. Catherine University and a Doctor of Philosophy degree in rehabilitation science from the University of Minnesota. She has assistive technology, professional in seating, and mobility specialist certifications from the Rehabilitation Engineering and Assistive Technology Society of North America. Dr. Vos-Draper's clinical experience spans more than 20 years, specializing in spinal cord injury rehabilitation, assistive technology, and wheelchair seating and mobility. Her research addresses complex occupational performance challenges related to pressure injury prevention using technologies that provide feedback on performance and efficacy over time. Our next presenter, Christine Olney, is a nurse scientist with the Minneapolis Adaptive Design and Engineering, called the MADE program, at the Minneapolis VA Medical Center System. Her research focus is on prevention of pressure injury, primarily focused on veterans with spinal cord injury. She also supports work with veterans who have lower limb amputations. She works collaboratively with the multidisciplinary MADE team to conduct research to include leading the qualitative inquiry process during the iterative design and development of research projects. This cohesive team of clinicians, MDs, OTs, PTs, and nurses, engineers, and specialists design, develop, and test adaptive devices for veterans. Other collaborations include working with scientists and clinicians from the University of Minnesota, the Mayo Clinic, University of Washington, and numerous VA healthcare facilities across the nation. Her current projects include refinement of a comprehensive mobile pressure assessment system, development and testing of a skin self-monitoring tool, development of a falls-related outcome tool, and testing dosage and utility of a mobile manual standing wheelchair. And our next presenter is Melissa or Missy Morrow, who is a professor in the Department of Nutrition, Metabolism, and Rehabilitation Sciences in the School of Health Professions at the University of Texas Medical Branch. She is the A. Russell Shearn Moody Distinguished Chair in Neurological Rehabilitation. Dr. Morrow received a Bachelor of Science in Engineering from Tulane University, a Master of Clinical and Translational Science from Mayo Clinic, and a Doctor of Philosophy degree in Biomedical Engineering from Mayo Clinic. Dr. Morrow completed a postdoctoral fellowship on an NIH T32 training program in rehabilitation and was an NIH K-12 scholar on the Mayo Clinic Building Interdisciplinary Careers in Women's Health program. Dr. Morrow is a biomechanist and rehabilitation scientist with an interest in understanding and improving physical function during daily life. She utilizes technology, wearable sensors, mHealth, motion capture, etc., survey-based and qualitative methods to better understand how disability impacts the lived experience. We'd like to take this moment to welcome all of you for presenting today. Next slide. And I will hand it over to you.
Okay, great. I'll go ahead and get us started. We have no financial conflicts to disclose. Our work has been funded by the Department of Defense, Veterans Affairs, National Institute of Health, and the Craig Nielsen Foundation and Mayo Clinic. The contents of this presentation and opinions expressed do not represent the views of the Department of Veterans Affairs or the United States government. Okay, so this talk is divided into 4 sections. First, I'll review some information about the etiology of pressure injuries and focus on those factors that our work specifically addresses. Then Dr. Morrow will share information about how technology is used in interventions to address pressure injury risk. And Dr. Olney will provide an overview of our project. And then I'll return at the end to share some case scenarios to highlight how we can use streaming pressure map data to zero in on individuals' needs. Okay, so this is the most current definition of a pressure injury by the National Pressure Injury Advisory Panel. Our project addresses pressure between a wheelchair user and the surfaces that they sit on. There are many factors that lead to sitting-related pressure injuries in wheelchair users, and many of them are listed here. First, we have pressure beneath bony areas along the sitting surface results in deformation of the soft tissue. Magnitude of pressure and time are important factors here. Interface conditions include shear forces, microclimate, which is heat, humidity, and shear. And these factors all work together to weaken the skin, making it more susceptible to damage. And then the individual's physiology, anatomy, mobility, and sensory function also need to be considered, and these all change over time. So as clinicians, we consider all of these factors, and then we individualize our interventions for each person. For example, clinicians often use pressure mapping, shown up here in the right, to see what's happening with pressure distribution at that seat interface. But we also ask a lot of questions about how people are managing pressure. How often are they doing weight shifts? What's their typical weight shift regimen? Do they have thick seams or pockets in their clothes that we might need to manage? What else do they sit on and for how long? And then what other kinds of activities they might be engaged in throughout the day. So the assessment process really relies on that patient's ability to accurately self-report to us as well. This diagram outlines the cascade of tissue damage, and I won't go through this in a lot of detail, but just basically prolonged pressure results in sustained deformation of the cells and soft tissue. This results in cell death, which causes an inflammatory response. And then as edema increases, it distorts the surrounding cells and it limits the removal of metabolic waste. More cells die, and the cycle keeps going until there's some sort of intervention, which ideally is removal of pressure, and that allows that skin and that tissue to recover. So the goal is really to interrupt this cycle as quickly as possible. And to do that, we need awareness that there is pressure in that region and a way to know when the pressure has been effectively managed. We know that for people with a spinal cord injury, there are unique factors that make pressure injuries one of the most serious and impactful secondary conditions experienced across the lifespan. So to highlight just how challenging this problem has been for our field and for the people who experience pressure injuries, while the incidence of other secondary conditions has decreased, pressure injury incidence has remained unchanged for the past 40 to 50 years. Here we have listed a few statistics about the impact of pressure injuries. They affect about a third of the SCI population at any given time and add considerable cost and burden to the individual. Programs that increase touch points with clinicians, such as seating experts in a systematic way, have been shown to be effective in reducing hospitalizations, emergency department use, and overall cost associated with care. The downside of that is that those programs require resources, so people and financial support. But according to a recent cost modeling study, they support the idea of applying resources broadly and early on using clinical monitoring or implementing new technologies to enhance early detection of stage 1 and stage 2 injuries before they get worse and more costly to manage. And so in all of the models that this group put together, there was cost savings in over 99% of the time when these preventative measures were implemented early. And so the system we are working on, we'll share with you today, focuses on both monitoring and early detection of problems. Clinicians address pressure injury prevention across the spectrum of care. Initially, the focus is on training and education, but then the intensity of clinical involvement drops off and may only occur when there is a problem. So as the risk increases with age and time from onset, contact with the experts actually decreases, and often when people need it more. So a big clinical challenge is that for most patients, we don't have access to objective or continuous data about how pressure is managed all day. In the clinical environment where we have access to pressure mapping, we are limited in understanding pressure across the full range of functional activities and postures. We also rely heavily on self-report about pressure management, which, as we know, can often be unreliable. And clinicians understand how difficult it is to adhere to pressure-related guidelines. The fact that there are so many fitness and nutrition apps and services are a testament to how difficult routines can be for all of us. Wearable fitness devices and food tracking apps can provide us with individualized feedback. And speaking from experience, it's difficult to rationalize poor performance, whether it's for exercise or sleep, when I have that data staring at me on the screen. So the primary takeaway from this first section is that we know pressure injuries are a big problem for people living with a spinal cord injury. They are hard to prevent, but if they are detected early, more serious problems and cost can be avoided. And clinicians in general have a lack of data that can help them guide their patients in an individualized manner.
All right, thank you, Dr. Vos-Draper. So, and thanks for everyone for coming. I see a lot of friends in the participant list, so it's lovely to have you all here. I'll jump into the conversation now. So Dr. Vos-Draper set the tone that there are these gaps, there are these challenges, and I'll jump in to say, well, there's been technology development over the past years attempted to address this technology. What have we learned from it, and where are we now? Next. So to get us all on the same page, a lot of the technology is really focused on understanding weight shift as it relates to the distribution and redistribution of pressure. So what you see on the left is a list of kind of and visuals of pressure maps of kind of the standard weight shift instructions that are given to patients in terms of whether you do forward leans, if you can, partial leans, right, left. But when we want to think about weight shift during daily life, there's a whole other list of activities that can account for shifts of the trunk and the pelvis, which will cause redistribution of pressure. And you see that list there, and largely we know very little about what that looks like during daily life and the pressure distribution of those activities. Next. And so what do we know actually from daily life? Well, multiple studies have looked at behaviors during the of wheelchair users across multiple days. And so to put the results in context, that neuro-intact individuals shift weight 6 to 10 times per hour. But we see from these 3 studies that are highlighted here that folks who use wheelchairs, power and manual, are often moving less than once per hour. The movement patterns are quite inconsistent. There are often hours between individual movements, whether they're minor or kind of major shifts, and that there's a far reduced number of offloads per day when compared to neuro-intact individuals. So the thing that stares us in the face is that weight shifts seem infrequent, and so there's quite a gap and a need to help address that. Next. And so when we think about those barriers and we think about technology being able to bridge the gaps, just in terms of the next couple slides, our team has thought about it in these 2 constructs where technology can help. So in self-management, what sort of technology could be provided to the individual to support their own performance of sufficient quality and quantity of weight shifts? But also, what can we learn from measurement on just characterizing what pressure looks like during daily life? This is still a wide open field of knowing what it looks like across the day and understanding what information can guide the individualization of a recommendation for pressure weight behavior. Next. So thinking of self-management, this is just kind of adding more context to that term. It's really complex. There's a lot of things that need to be addressed in terms of a technology that would aid in self-management. And those barriers to address include the cognitive burden, the time it takes, whether there's help needed from a caregiver or other third party, how just having to be in having to change behavior will change your daily life, will interfere. There'll be other unknown risks throughout the day, and the need to be consistent. This needs to be a consistent behavior change to elicit the prevention we're looking for. Next. And so to summarize, it's complex, and the self-management plan requires individualization. Next. Well, measurement barriers. So we know we need more information to guide individualization, but we don't have a lot of that information yet. We don't know what movement behavior metrics are clinically meaningful over the long-term monitoring aspect. And so we think about what might technology to be able to provide us. There's some metrics here on the right in terms of pressure or force. We can understand the center pressure, peak pressure index, distribution or dispersion index, which looks at that distribution across key areas under the pelvis. We can look at frequency metrics, weight shifts per hour, for example, the magnitude and quality of movement. Someone might be consistently doing their right leans, but they have no idea that when they lean, they're really not offloading enough to make a difference to their skin. And then the intervals between weight shifts. Next. So if we look back at the timeline, much of this work began in the 1960s, and it was really focused on training behavior in a short-term format. So technology that was introduced was often aversive. It was almost like, in kind of current speak, it would be very much like shame-based, trying to shame folks into moving. So very loud noises that you wanted to avoid by doing the right thing, by moving enough. That advance into maybe some more positive forms of feedback in terms of reminder time and timers, alerts if things aren't looking right in terms of the data that might be collected from the chair. Still a focus on training behavior, but a positive aspect of adding compensatory strategies started emerging. And if you look at what's happening now in this field, there's just an abundance of different types of sensors that are being trialed out for more long-term use. There's enhanced feedback, which you're going to see a lot of examples of. We're tracking behavior patterns more long-term, and really trying to assess the importance and what we can learn from implementing clinical access to this daily life data. Next. So from the early technology that was focused on the training behavior for consistently, we did see that if prompts are given, movement increase. If you remove the prompts, the movement behavior increases and that alarm avoidance was effective. But these were short-term solutions that showed short-term effectiveness, and the story kind of ended there. Next. And then if we look at what's available now, we want to, pay our dues to the virtual seating coach, which really provided the first commercially available system of long-term monitoring with engagement with a clinician dashboard that was available for power wheelchair users to really understand the positioning of their body in their seat and to be able to track those behaviors. Additionally, on the market, as just one example, is from Sensoria, which can be used, can also be used in manual wheelchairs, which include sensing underneath a cushion that can provide feedback on the number of weight reliefs and can count them throughout the day. But there are other systems that are either on the market or close to being on the market, as I have listed. Next. And you'll hear a lot more about our system, but I want to put it in context of it's not commercially available, and we'd like, we term this an emerging technology. Similar to other systems, we are focusing on long-term use, but I'd say that there is quite a focus on a really robust in integrating with clinical care and that feedback of the data being provided to the patient and clinician and what that's going to look like. And then additionally with some expanded being developed and tested through multiple ongoing projects. But Dr. Olney will talk a lot more about our project next. So next. So current evidence from our studies and others that are using technology that's either available or emerging is really focused on usability of the systems, on the development of those systems and testing with users. And results of that, are really clear that the simplicity and reliability is key. There are ongoing validation efforts of the weight shift detection algorithms across multiple systems. Some of the data absolutely shows that prompts and alarms are useful in increasing movement, with the caveat that these studies are still considered rather short term. They're not over a day, but we're now building up to weeks of testing. And then something from our data that's been compelling is, as I alluded to before, whether or not you perform a weight shift is great, not know how effective and the quality of that weight shift. And so seeing live pressures from our data has shown to improve self-efficacy of the individual. However, we still don't have this type of data connected with clinical outcomes, and we don't have long-term data available yet. Next. So key gaps that need to continue to be addressed in our system and other systems and research going forward is a real need to have software and hardware integration as seamless as possible for the clinician and the patient. And I think there's a need to really put a lot of time and money on this aspect to really set the implementation up for success. We don't know exactly what movement behavior metrics are going to sort of end up being most clinically meaningful over the long-term monitoring period. And that's a really exciting area of research that's just ripe for this type of data collection. And then lastly, that loops into the others as well, as we don't know the effect on understanding this data from daily life in the clinical context and how that may improve clinical care over time. And I'll hand it now over to Dr. Olney.
Thank you, Missy, for that overview of the current technology. So now for the next 10 minutes, I'm going to share our journey. This is a multi-site, multidisciplinary approach with the goal of creating an interactive device aiming to enhance the end user's ability to remain pressure injury free. So our group is specifically focusing on seating behavior as influenced by awareness of risk, weight shifts, and seated pressure. Next. Thank you. So in clinical practice, patients were regularly asking Dr. Vos-Draper for access to pressure mapping, and requests range from like wanting to see the maps on other surfaces to wanting to take Tammy's seating clinic pressure mapping system home with them or to buy one themselves. And of course, to buy one would be cost prohibitive. And then there's the problem with the data. It's really relevant for the clinician, but not really relevant for that personal user. Next. So The idea of on-demand access to pressure mapping started with this early conceptualization. The wheelchair user would access the pressure map feedback at home using the smartphone in real time and when they wanted or needed it. So in the lower left-hand corner, that's exemplifying that. And then if you follow the arrow to the center, there's a very light gray colored cloud there. That's representing that app that would be shared, share those data with the server and storing the pressure data and app interactions, and some calculations would be performed in the cloud and then returned to the user for tracking information over time. For example, users would be able to play back saved pressure mapping sessions. And then conceptually, we thought clinicians could access the pressure map usage data for the server in the format relevant to the clinical setting the patient needs. The server would provide a potential two-way communication between the clinician and the wheelchair users. And then finally, that center icon depicts that during those clinical encounters, access to the information about the pressure is managed throughout the daily life and would facilitate the clinician-patient relationship and allow the personalized goal setting and the ability to address seating issues before they become serious. Next. So the team began with the development process with following 4 objectives in mind. We've engaged with wheelchair users and clinicians from the earliest stages of development. And so when we thought about feasibility, the way we empowered that, we tested the iteration in the lab first, and then we went to the setting in which it was intended to be used. For usability, besides gathering information during the focus groups and interviews, we've utilized standardized tools such as the System Usability Scale and the User Experience Questionnaire. That's the SUS and the UEQ, if you're familiar with those, to evaluate how well the end user can use the equipment and understand the information that they see. For efficacy, we're really interested in how using pressure map feedback impacts the wheelchair user's self-efficacy and pressure management behaviors. These include weight shifts and actions to detect problems or behaviors early on. And our major objective is to have that long-term impact for reducing those serious pressure injuries. We're also interested in the clinician's self-efficacy for addressing pressure injury prevention. Regarding implementation, we're now engaged in exploring implementation and with the full system with our clinical practice, both inpatient and outpatient, and we'll spend a little more time in a little bit telling you about that. So our projects for this development have spanned from 2012 through 2024. We have funding for, and we have about $7 million that we've received for this project. And in combination, we have a number of teams, as you can see at the bottom, including Mayo, Minneapolis, VA, University of Minnesota, University of Texas, and Georgia Tech. So we've come together to work on this project. Next. So here we've added some lines to show how each initiative really relates to feasibility, usability, efficacy, and implementation, and how we've addressed those in each of these studies. As a system evolved and continues to evolve, we have assessed and reassessed the intended functionality for both the wheelchair user and the clinician. You can see the names of the overall system has really changed throughout time. In those first studies, it was a PMAP for a prototype mobile pressure mapping system. Then it became the comprehensive mobile assessment pressure. And then, and now it's called assistive weight shift. We're working with 2.0 version now. We also feel like we've been quite successful because we have used this iterative back and forth development process and in a user-centered design. And I also wanted to share that for data analysis, to give feedback immediately or as quickly as we can to our engineers, we use the Hamilton Rapid Assessment Analysis process. Next. So early on, Drs. Vos-Draper and Dr. Morrow conducted some feasibility studies. In this study, they got some positive feedback from the users, and that really gave them the green light to carry on and carry forward with the concepts that they had. And early on, those users found that the visual feedback was helpful for checking their pressure throughout the day. They liked that it could guide their caregivers for positioning them in the wheelchair, and for the wheelchair user to be able to see their seated pressures at home. And as you can see, this quote is very validating, and it really helped them move forward. Next. So at the same time that Drs. Vos-Draper and Morrow were working in the early prototype project, at the VA, our clinicians and researchers were querying our veterans about using that smartphone app, and asked what motivating features might be on that to help them impact their seating behavior. The colors in this graph depict levels of motivation. For instance, blue is for highly motivating, red is for motivating, and the green depicts not motivating. And you can see clearly here that the veterans reported that seeing maximum pressure and live pressure map, they considered motivating and highly motivating. And they also reported that reminders, time since last weight shift, and seeing a summary of their pressure reliefs as motivating or highly motivating. Next. So further on, earlier, during those early phases, we used the very first prototype. It was very basic, had a very few features. There was a live view of the pressure and some information about how it was distributed between the back, left, and right sides. We learned that continuous and on-demand pressure mapping as a personal tool was possible, and that users found the information valuable. And the second image here, this was during our DoD-funded project. The app was completely rewritten, and that was based on our engagement with our veterans with spinal cord injury. Veterans wanted a number of things. They wanted reminders to perform the weight shift. They wanted to see alerts if the pressure changed dramatically. They wanted the ability to record and play back pressure maps, and several other things. Now, all the weight shift events were manually triggered by selecting start. From this research perspective, it allowed us to do a rewrite to capture some of the information on the server and to understand how the user was engaging with the system. Then in the NIH-funded project, the CMAP again was rewritten, and this time as a native app, and we began to leverage more of the server-based tools. The server allowed us to conceptualize that early dashboard for clinicians idea, and weight shifts were still being manually triggered at this point. We had some other hardware parts of the system that changed during this period, including the new way to secure the map to the seat cushion and improve the connection with the Bluetooth technology. And then finally, during this VA merit that's ongoing right now, the app was reworked a second time, and clinical dashboard was created. The app functions are now both an iOS and Android-based systems, which includes the smartwatch functionality. Now the system's able to continuously stream pressure data all day long. So there are a lot of data about pressure management that we haven't had access to before now. The system also detects the events automatically now, and the dashboard rebuilt has been based on clinical feedback, and we're really grateful for that. We'll go into more detail about that with the last section with Dr. Vos-Draper. Okay, so you know, we really needed to hear from clinicians whether or not they would find these data valuable, and they said absolutely yes. In our focus groups with the clinicians, we heard what would be particularly valuable on the clinical dashboard. They wanted to see the quality of the pressure management, not just whether the weight shifts were performed. And so they provided a lot of detail about what they considered to be a quality weight shift for us, and they required that pressure distribution change enough to offload at-risk areas during that weight shift. So it's been very helpful. This slide really is interesting because we went out and surveyed assistive technology certified providers through the RESNA database. We got 362 responses, so that made it quite powerful, we thought. And they were in quite a bit of agreement about pressure map data and how valuable it would be. Next slide. So where are we now? We have this ongoing study at the Minneapolis VA, which we will be using the OSHIF, which we are using the OSHIF 2.0 system with 6 veterans in-house. And we have 3 PTOT seating specialists who are testing the dashboard features. They're really helping us refine that dashboard. Soon we'll be recruiting 20 veterans to test the system in their homes, in their home environment and community environment. And the clinicians will be able to access the dashboard again to check in on them. So there's another ongoing study that we have. Dr. Vos-Draper and Dr. Morrow and Dr. Shearn from Georgia Tech, they're conducting a they're conducting a study in the community, comparing use with and without technologies. And in that study, there are 60 folks who are testing both the wheelchair user outcomes and the remote monitoring from the clinician end. So I'm going to turn it back over to Dr. Vos-Draper, who's going to walk through some case scenarios to kind of show you the functionality of where we're at with the system.
All right, thank you, Chris. So in this last section, I'll demonstrate how access to the streaming pressure map data has a lot of potential to guide clinicians in making individualized recommendations for managing pressure. So as I move through the various features of the software, I'll share how they're grounded in and relate to and address specific challenges. The 8 lifestyle principles shown here are described in the 2010 paper by Jackson et al. These researchers conducted a series of in-depth interviews with 19 people who had experience with pressure ulcers. And from these interviews, 8 specific themes around the challenges in managing pressure emerged. If you haven't reviewed this paper, I encourage you to. As a clinician, the stories from the interviews were really familiar to those that I heard from my own patients over the years. Okay, so the first 3 slides that I'll go through describe what the wheelchair user sees on their end through the mobile app. As you've heard from Dr. Olney, these features have been refined over several different projects to meet requirements from the wheelchair users and from the clinicians that we've engaged with. And so first of all, to provide awareness about pressure distribution, the user sees real-time pressure at rates similar to clinical mapping systems. And I'll play this video so you can see that happening. The user can also view the live map on their Apple Watch. And so when the user performs a weight shift that relieves pressure in peak regions, shown by these little squares, an activity is detected, and then it's recorded as a weight shift. And then over on this side, you can see that the user has complete control over the settings that they can use to individualize the feedback to meet their needs. And clinicians also have the option to remotely adjust these settings in real time. So here we see that the settings for the activity detection allow a high degree of individualization that focus on that pressure management directly at the seat interface. And so the thresholds for detecting activity and a few other criteria can be individually selected for the people using it. And so the principle of this perpetual danger is addressed through several different types of alerts and notifications, and a couple of them are shown over here on the right. And these show unexpected pressure changes that are intended to help the user identify problems early so that they can take action. Daily, weekly, and monthly tracking of performance patterns allows the user to monitor their prevention routines over time. So on the watch, for example, one of the screens shows progress toward their daily goals for managing pressure. Over time, a user may be able to see trends about decay in their prevention routines, for example, and these tracking metrics may also provide some motivation to users who are motivated by that type of data. All of the pressure map data streams to the cloud at regular intervals, and so it's recording continuously and saving full days worth of data. And that can all be replayed in the future by looking back in time. So for example, selecting one of the shifts here on the daily report brings up the pressure map recording for that entire shift. Okay, so now we'll shift into the clinician-facing view. Clinicians access this dashboard through a secure website, and the dashboard uses all of that raw uploaded pressure map data to derive several different kinds of metrics and reports for the patients on their caseload. And so for each patient, they can see whether they're actively using the system or not. They can get a quick overview of how many hours they're generally in the chair or using the system, how many quality weight shifts they've done for that day, and I'll talk a little bit more about that. They can also see what that patient's current goals are, and then how well they're doing toward meeting those goals. At the bottom for that patient, I can click on additional features. I can have flagged events that I can review. I can print reports that I can use in my medical documentation, and then I can click on shift history, which takes me into a deeper dive into that person's daily performance patterns. And so if used as a remote therapy tool, this system has potential to improve access to services for people who live, far away from seating clinics, for example. Okay, so clinicians shared with us that they wanted to observe patterns of behavior within days and across days. And so here is a view of one user's full day of pressure management. For each hour, the small icons represent pressure-related events. So you see these icons along the hour here. And then hovering over one of those events provides a few more details like time and duration. Clicking on the event brings up a video that shows the entire pressure map recorded during that event. The clinicians also wanted to see specific metrics. They wanted to know, when did the pressure relief happen? How was pressure distributed and for how long? And then what was the duration of that pressure relief? And on this view, the duration of the reliefs are kind of shown by the size of the blue icons. So that gives me a quick overview of short versus longer weight shifts. So these features address more of the lifestyle principles of individualization and lifestyle risk ratio by showing a more detailed overview of the daily routine. In this view of the dashboard, trends over longer periods are shown. Colors on the bar represent duration of the shifts performed each day. Clinicians wanted simple figures that used color so that they could take in a lot of information quickly. So this information can also be viewed across a full year. And these charts address the lifestyle principle of decay or disruption or change in routine, because it allows us to really see those trends over time. Okay, so I'll play a short video here while I'm talking. This is showing some interaction with that daily figure hovering over the different icons and then pulling up the event videos to replay it. And there's some control over how fast to replay those videos. And so this really allows the clinician flexibility in how much information they see at any given time. They can pull up maps, for example, from a full hour and then replay those if they want to. And of course, you'd probably want to speed those up because clinicians are busy. But they have access to all of that data when they need it. Okay, and in the second video, oops, let me click forward. There we go, sorry. In the second video, after viewing a specific range of pressure data, the clinician can then view and interact with some line plots. And these line plots show several different metrics that the clinicians asked for: center of pressure, average pressure, dispersion index, and peak pressure index. There's a lot of detail here. You can see when the weight shifts are occurring by looking at the blue shaded areas, but then you can see in more granularity how much the peak pressure index was reduced during that weight shift, for example, or how average pressure changed over the full day. And so looking at a full day plot like this makes it easy to see kind of what that overall daily routine or pattern was and how that impacted pressure. So next I'll walk through a scenario for using this dashboard clinically. And so this is hypothetical, but this patient is returning for a follow-up visit as an outpatient, and there have been concerns about pressure management. And so we can use this dashboard information to help us prepare for the visit. So my observations as a clinician, if I'm looking at this, would be that this user has a goal of doing their weight shifts 3 times per hour, and they've spent about an average of 2 to 3 hours most of the days in their wheelchair. And then I can see they haven't completed any of the quality weight shifts. That means they weren't held long enough to count as a quality shift. And they haven't met any of their daily weight shift goals that are shown. And so I would use this broad overview to kind of check in with the patient about how they think things are going with managing pressure. While the first instinct might be to show the patient how non-adherent they've been, this information can really instead steer the conversation toward realistic goal setting. It's possible the thresholds were set too low or that other settings might need some adjustment. It also could be that the user just wasn't aware that they weren't holding their shifts long enough to meet that quality weight shift goal. And so access to this data allows me as a clinician to focus in on any specific challenges the patient may be experiencing versus just reiterating the guidelines and expecting adherent weight shift performance. So observing the month-long data for this patient provides insight into any trends or performance of weight shifts. And I can see right away that there was one day that it looked like this person had a good mix of long weight shifts, medium length weight shifts, and short weight shifts. I would look for consistency in the data across days. I would look for any days where I might want to use it as an example of a day that seemed to go really well. And then I would pull those up during my visit and share that with the person as an education tool. So if I want to pull up that specific Sunday as an example to share with the patient, as an example of a good weight shift day, I can pull up these details. And here are some observations that I can make with this person. Most of their pressure relief activity is occurring early in the day. So between 12 and 2. Pressure reliefs between 3 and 5. They did a few, but they were really short. And then there were no pressure reliefs for at least an hour, maybe 2 hours here in the early evening. And then there was some time out of the chair. They received an alert for high pressure, but I noticed that they did some weight shifts right after that. So it looked like they were taking action to try to solve that problem. And so I would commend them on, being aware and alert and taking action where needed. Some other ways that I would use this information with the client would be I could discuss those differences from early afternoon to evening and just understand their routine and what they're doing during the day. I could encourage longer duration holds in the mid-afternoon. Again, this person might not have been aware that they weren't holding them long enough. And then I would also probably set a goal to increase weight shifts in this early evening period. Maybe I would start with, your goal is to do one weight shift between 5 and 7. That counts as a quality shift, and then just keep increasing that. And that way it keeps it realistic and something that person can strive towards. So during the visit, I could also replay a pressure map recording from a weight shift event with the patient. And so I'm playing this while I'm talking here. So in the recording, I noticed that there's high pressure overall throughout the ischial well. I also noticed there's not a lot of pressure under the thighs. And so this might allow me to have a conversation about whether they're using different types of shoes from day to day, maybe different shoes than they used when they were in the clinic. And then whether or not the foot plate height might need to be adjusted to get more pressure distributed out here under the thighs. And so having access to this more detailed information about pressure in a person's real life activities allows us to detect some of those subtle issues that might not have appeared during that routine clinical visit. Now, for the clinicians out there who love data and objective measures for documentation, will really appreciate this. I can review the line plots that appear below each of the event videos. So these are the line plots for that weight shift that I just played on the previous slide. Here I can verify how far the center of pressure shifted along the vertical axis. I can see the decrease in average pressure and I can quantify it. I can also see which regions of the mat had reductions in peak pressure index and how large those reductions were, and then the same for dispersion index. So clinically, this provides some really objective data that I might be able to use to justify any change in equipment if needed, or even to show a positive response to skilled intervention. So on this last dashboard view, this user's activity on a different day, here you can see that the person was quite active with well over 100 weight shifts detected. This might indicate to me that either the settings were too sensitive, or maybe they were engaged in multiple PT or OT sessions or some other type of training. So if so, we could kind of check to see how pressure is managed during those activities because we can play them back. And so the pressure image on the right is a composite image showing the day's average readings for each cell. And here I can verify that the lack of pressure under the thighs seems to be a trend. So this wasn't just on that one day during that one weight shift, but throughout the whole day on a different day, I'm also seeing not very much pressure under the thighs. So I would definitely want to address that. Okay, so I went through this really quick, but this concludes the overview of the user-facing software and clinical dashboard and our presentation today. And so you've heard about the clinical challenges around pressure injury prevention and a few ways that clinicians and wheelchair users could use pressure mapping data to provide more insight into pressure management and for individualizing our recommendations. Okay.
Thank you so much for your excellent and engaging presentation today. So at this point, we'd like to invite participants to ask questions. You can do so through the chat or through the Q&A. So we have one question in the chat. Someone asked, will use of a standing power wheelchair show up as out of chair on that data?
That's a great question. I'm glad you asked because we're still kind of experimenting with that in our I think Chris, was it in our inpatient study or maybe Missy in our outpatient trial? We had a user who occasionally used a power chair that had standing. And we did need to make some changes in how we were detecting weight shifts. And so it can detect a difference in weight distribution and pressure distribution. If it's significant enough, it might indicate that they're out of the chair, but that just means we'll need to go in and kind of change those thresholds and kind of keep tweaking those until it works well for that user with the standing chair. It's still something that we're kind of learning more about, but definitely something to consider.
There's a question in the Q&A. Someone asked, at this point, what would you say is the best and most feasible way to move this information forward to our patient groups? Not everyone will have access to the PerMobile app or the, I'm going to pronounce this wrong, Sensoria tool.
Yeah, I think that just ongoing research to show efficacy and to learn as much as we can about, does the system work and does it continue working over time? We know that, for all of us, when we get new devices that track our behavior, we might use them for 3 months or 6 months, and then maybe we don't look at them anymore. We don't know enough yet to know, how long people will use a system like this. I think that the next step is really continuing to collect those outcome measures and understanding, does this change behavior and does it have an impact on the incidence of pressure injuries if people are able to detect problems earlier?
All right, I don't see any additional questions coming in. So to wrap up today, I just want to thank everybody for attending today's grand rounds, and thank you again to our presenters. If you have any questions that you didn't answer during this time, please feel free to reach out to one of the presenters directly if you would like to follow up. And the recording for this webinar will be posted soon on our SCIMS website with a link to our YouTube channel. As a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar. At the end of the webinar, a brief 3-question survey will pop up on your screen. We would greatly appreciate your feedback. We also hope you can join us for our next grand rounds on Thursday, January 5th at noon Central Time, where Dr. Jessica Nielsen will present Weighing the Risks and Benefits of Psychedelic Therapy for Spinal Cord Injury. Thank you again for attending. Thank you again to our presenters, and have a great rest of your day.
Thank you.